lung cancer is one of them. Prostate cancer is one of the cancer which is a fascinating story. And some of the concept, and this I tell my students, and again, Amit is there because we discuss a lot. Nowadays, Amit is busy with abstract. Otherwise, we used to have a discussion every week. We used to sit and what has happened in science and we were taught and what happens not always is true. And as the time goes by, how the concept completely changes. And we forget this is what was taught and this is what I used to teach. So we'll try to talk about some of them. So Nobel Prize, more than one because of prostate cancer, especially hormonal therapy. So this was one of the surgeon who, got Nobel Prize because, this was surgeon who discovered, who initially found that we have a prostate cancer. So this was Dr. J. Adams. This is overall what has happened and how the prostate cancer development has happened in the past or till 1971. Yes, this is what I was trying to mention, and thank you. This is what I was trying to mention, that yes, you had someone who developed that this is the hormone dependent cancer, and if you do castration, and then the patient benefits, and the patient and this person got a Nobel Prize for it, and that was Charles Huggin. Then you do have the good thing about is it doesn't trouble patient much. You do have some side effects, but by and large, patient will be thankful to you if you give hormonal therapy or castration to the patient of prostate cancer. Why subsequently it fails if you give do castration? Because with the time we learned that you do have these hormones produced at some other places, that is from adrenal, it's the androgen produced from adrenal, and that is what overrides what you have, and then you have various other pathways. And it's not easy at that time to work on it. And that was the reason removing adrenal or removing pituitary was not possible. So if you have resistance, you couldn't do much. So there was then LHRH developed, androgen deprivation therapy. Again, this was Dr. Andrew Shale, who again got a Nobel Prize for developing this. So you have something effective, then you do get Nobel Prize, and something which has not changed. It has been so effective that we have been debating for last 15 years, and we couldn't put a protocol. We always wanted to know that what happens, this castrate-resistant prostate cancer, can we remove LHRH? If you do orchidectomy, good. But if you don't do it, can we remove the LHRH? But in spite of knowing that after 2-3 years, usually androgen production goes down substantially in testes. But we have not been able to put a protocol because the kind of impact it has in these patients that as on date, we have not been able to do it. And as much we want that 2 years, 3 years, or 4 years, and then you want to stop it. Today, you start from hormone-sensitive prostate cancer. You start this androgen deprivation therapy. You continue with CRPC. You continue with second line. Usually, you don't stop. So that is the kind of impact it has had. Now, because of this impact, okay, this is the benefit and some drawbacks you have. That's not important. Benefit, we know that it really controls it is better. These are some of those other ADT, which is there, and you had various pathways where the finally androgen gets formed. If you block it, and you do have ADT. And apart from that, apart from LHRH partial agonist, you have antagonist, which is available now, which we use routinely. Again, similar activity. The benefit is that you don't have a flare because it is antagonists. Apart from that, what we talked about, that why androgen deprivation therapy fails, that if you can give, you can do medical because the androgen gets produced from adrenal gland. If you can do some drugs for it, there was some in the past, some good drugs, but not so great. And that's the reason they're not commonly used. We were never happy for it. If you ask me, in our time, ketoconazole was there, but we didn't want to use it. And again, I repeat, because Amit is there, we have seen this things changing in our time. We used to never wanted to use it, ketoconazole, in our patients. So you had some other drug, cyproterone, they had some issue regarding it going to the brain. So you have cipeterone acetate, some activity, again, not so a drug which is patient friendly. And that's the reason you won't remember these names. Drugs which are very effective, they continue, they remain there. Remember the activities, and these are some drugs which keeps coming in between. We have some activity, we do use it, but we are not so keen about it. Now, some other drugs which are, which are anti-androgen and which is relatively useful, like flutamide, baclotamide, nilotamide, which has got some activity. Again, there was useful drugs. Again, not exceptional. Why I'm saying not exceptional in today's context, don't get me wrong. In those time, I remember ketoconazole in prostate cancer came. I was doing MD medicine, and what my professor's father had this, and it was a big story of that. Okay, ketoconazole. But again, I do remember that he didn't take it because of the toxicity. So these were good drugs in those times. But I'm saying in today's context, again, good drug, but not exceptional. There was a concept of combined androgen blockade, that you combine it apart from giving LHRH analog, combined anti-androgen, and hopefully we'll have a better outcome. Multiple studies done. This was someone positive study. So talked about initially good, but subsequently you have 27 randomized trial, whole lot of studies done, combined. But finally, what we conclude is that it has marginal benefit. You may or may not combine. You may combine to reduce the flare. Otherwise, sequentially is not a bad option in this setting. This was for combined androgen blocker. Now, because it was not very active, so the moment in science happens that something is not active, there is unmet need. There are smart people. There are smart people like Akhil, and which will try to find out something that what can be done. What can be done to have solutions. And these were some of the solutions which was there, that you have a better systemic therapy or try to do some local therapy. And people have done that, many of them. Now, coming to two of the concepts which was there in our time and just highlighting. One was concept that prostate cancer is chemo-resistant tumor. Sure, Pradhan sir will remember. In his time, because it was in our time, so I can say that it was in his time. And we used to never thought. Docetaxel came in when I was doing DM, and it was in second or third year when it was in castrate-resistant prostate cancer. So initially in our time, our teaching was that prostate cancer is chemo-resistant tumor, so chemotherapy doesn't work. And one of the initial drug was extramustin. Then in 30 years, there has been a lot of development. The first one was mitoxantrone. Had some activity, no survival benefit, but it was part of all guideline. Only benefit was that it used to reduce pain. That was the benefit. And we used to use it, but a lot of grudgingly we used to use it, not very comfortable. And that too, we are not very happy about. If you get a patient from urologist, fine, you use it. They come also, we were not certain how much we want to counsel to use it. Again, the efficacy decides how keen we are. I'll come back. I'll give you how keen we are now as compared to earlier. We were not so keen that time. We were fine with, in our giant clinic, we used to sit together. Achha, theek hai, koi baat nahi, okay. Now it has failed, fine. If you send to us, you don't. Then subsequently, there was something which changed things a bit. And this was some real change. And that time, these changes were considered very good. I'll come to that. What do we consider now? And then you have docetaxel, tested in 2 trials, both showing that if you give docetaxel to these patients, there is improvement in survival. It was around 3 months improvement in survival. Remember, it is not easy to show with treatment improvement in survival in cancer. It's not easy. It may be small, but it's not easy. But it gave a good hint that it works. But again, I'd say with this data also, it was there. Again, in all guidelines, we were a bit more, willing to give chemotherapy, but again, we were okay in our JC with the patient. If it is CRPC, slightly also frail, no, please don't send, it's okay. Best supportive care after initial LHRH analog was a good option at that time also. But it did change the perception that no, prostate cancer is chemo-resistant. That is not necessarily true. Subsequently, not only you had a drug, you have another drug, we call cabazitaxel, and this was given our docetaxel. So taxane after a taxane, again, this is our routine teaching that you don't use similar group of drugs in a patient, but it appeared that if you give taxane after a taxane, another taxane, it works. And again, there was improvement in survival. That put this issue to the rest that, okay, it is a chemo-resistant tumor. So this was something very unusual for me, because this is what I had learned. And now what I was telling my student, I was telling something else. That, okay. And I'll come to some later effect, what happens. Now we have, we used to call castrate-resistant prostate cancer in our time, not in all younger people time. And again, Amit, we used to call it castrate-resistant prostate cancer because we used to do castration. And what it means, this was the definition. You can go in detail. Later, I'll just put a concept that there was some definition when you call castrate-resistant prostate cancer. And what it means, that now these patients, hormonal therapy doesn't work. That was the concept that you put. It's not like we don't used to use it. We used to use bicalutamide, but there used to be hardly any activity. And these are the mechanisms of CRPC. These are, then subsequent development. So what was the subsequent development? Again, I say some smart people, they keep challenging whatever is existing. And this is very important in science. They said, no, there are many things happening. They started blocking CYP17 hydroxylase, then androgen receptor modulation, and then you have a whole lot of options available. And we realized that concept of that in castrate-resistant prostate cancer, hormonal therapy subsequently may not work. That is not true, because now you have a multiple options, and it appears each of them has shown that it improves survival. So again, that issue got challenged. So showing you some of the studies, abiraterone, enzalutamide, and it appears they all work. And this was second concept, which was something for me a bit of a shocker for, because this is where we had grown in our time, and say, okay, now it is totally a different concept. So nowadays you don't call it castrate-resistant prostate cancer. You call it with a different name. You have some other development. You have immunotherapy, which was there. Dendritic cell therapy, not something great. It has not test the as the test has gone by, the kind of attention it had earlier, it don't have it now. But yes, this is one place, and this is the only place which I am aware of where dendritic cell therapy works, and it showed that improves survival. Again, one of the systemic therapy. Immunotherapy looks like again, but till now we call it. You can sure 5 years down the line, someone challenges and say no, it is immunoresponsive. Today looks like prostate cancer is not an immunoresponsive tumor. There are some group of them where it's pretty rare, where it may work. If you have MSI high, MMR deficient tumor, maybe it may work. TMB high, query bad, that is the place where it may work. There has been some other development happening, that is radium-223, again in castrate-resistant prostate cancer. Laterally it works, it adds life to the patient. And again, this is something which I was also a bit surprised that subsequent, whenever it has been combined, somehow the efficacy has not been as great. But again, a good option, especially because it works locally, it doesn't lead to lots of side effects, and it gives good palliation and maybe some improvement in survival also. Now, what are the options? These patients in CRPC, you had in second line, all the drugs for second line now have come in by and large in first line. So there is a separate issue about it, how we are going to use drug one by one. Now, that will be, that can be a separate discussion and in detailing. But yes, a whole lot of drug is in second line, which came on first line. So issue regarding how we are going to sequence, that is a challenge. Now, coming to this, we talked about, castrate-resistant prostate cancer, that is a hormone-resistant prostate cancer. Now, hormone-sensitive prostate cancer, in advanced setting. You use LHRH analog. By and large, we don't use it now because you have a combination of combining more than one hormonal therapy, or combining hormonal therapy, two of them with a chemotherapy, and that is what is far more commonly used. Highlighting that again, that which I talked about, hormonal therapy plus hormonal therapy having additive effect, which we have not thought earlier, that is possible. and chemotherapy moving from second line to first line, setting in hormones, in prostate cancer in metastatic setting. So again, having all the drugs which were there in castrate-resistant prostate cancer now has moved to hormone-sensitive prostate cancer, and by and large, it's going to here to stay. I'll just show those examples. I won't take time on this. Important is here for me is that the quantum of benefit. So what we talked about for chemotherapy or systemic therapy, when we talked about in castrate-resistant prostate cancer, so one we learned that not necessarily one concept is always true. And this was also true for me. Again, there are other tumors also, I see this concept happening. When you use the drug and when you use those treatment, the impact can be different. And this was very good in prostate cancer, because in castrate-resistant prostate cancer, if you use docetaxel, the average addition of survival is around 3 months odd. If you move to hormone-sensitive prostate cancer, the average addition of survival is around 13, 14 months, depending upon which type you want, which group you want. It may be 10 months, it may be 21 months. But this is now dramatically different. This we had, I was not aware. And when I saw this charted and stamped, and again, we used to throw each other's discussion. We had, does it matter when you use? So it looks like. Not only, this is not only true for docetaxel, this is true for abiraterone also. This is true for enzalutamide also. That somehow we move where you use the drug, the quantum of benefit what you get is different. And now, as I told, we have a trial showing that combining all three may be useful. And slowly what we're seeing, 5-year survival of around 60%. And always I compare with our ALL data, because that is something striking and people remember. So Indian context, in pediatric ALL today also, long-term survival remains around 70-75%. And I say, if you are achieving 5-year survival of 60% in metastatic disease, you need to be careful that you need to have those treatment with whole lot of resource to be required. We keep talking to our social worker, and this is our usual agony. Again, this is our usual agony between us. The social worker is always so sensitive about our pediatric patient, and there should be. And nowadays, there is a good sensitivity for women cancer, and which is again good. You see, somehow adult males are totally discriminated. So adult males with cancer, there is no resource available. Amit, is that correct? I mean, so we always tell our social worker, kabhi sochte bhi ho adult male ko bhi, you have a cancer and then you need to give some resource to them. And with this kind of data, good thing is that now they do listen. They do acknowledge that there are, in adult males, no, they're not wrong. They are doing the right thing. So when you have a smaller benefit with the treatment, then putting resources is not easy. So when we are able to show that you have 5-year survival, 60%, 70%, then the social worker also is willing to listen more that, yes, they are going to generate resource and provide those resources here. So yes, that looks, there is a significant change as far as the systemic therapy is concerned in prostate cancer and the outcome. I'll just pass on some of those. That systemic therapy has not only been there in metastatic setting, you have also in locally advanced setting. You had a study there which looks positive, and lots of studies going on. Stampedes also has a subgroup, again suggesting that systemic therapy works in high-risk group, and in UK they use it usually. And again, I see my urologist here. He will shake his head that prostate cancer, docetaxel in locally advanced setting 20 years earlier, but never have thought about it. But looks like that, yes, it is a part of routine care. In fact, abiraterone now we use routinely. In fact, all the trial run for radiotherapy by Dr. Vedang, abiraterone is part of all of them, because he also thinks it's not a good idea to go ahead without. 1 minute. Okay, I'll finish earlier. So now we have targeted therapy. You can't talk in oncology and especially medical oncology without having a targeted therapy. But somehow we do have something in prostate cancer. HRR pathway is deranged, and that is seen in almost 1/4 of the patient, depending upon which kind of patient and which kind of test you do, where you do in blood or tissue. That is again a detail for some other discussion. We call it germline or somatic, depending upon where we have done test and what kind of test we have done. And yes, you have now multiple studies, 1, 2, 3, there are more. And this is a summary slide showing that at least there are 3 drugs approved with a different kind of tags they have been given, where to use it. But idea is that testing for targeted therapy is important in prostate cancer, and you have got patients who can have a significant benefit. For example, if you have BRCA positive patients in prostate cancer, PARP inhibitor is a significant benefit. We can have a debate all those subgroups, but in general, the message is that there is a requirement for doing mutation testing in prostate cancer. Apart from that, what I'm not showing is NTRK. I showed about MSI, where you have some treatments which are useful, and there are patients who ask for everything. So in that situation, it is useful that we have. And we will be, again, this will be reading again and again, molecular profiling of all the cancers. And this also amazes me when I had started practicing that time, molecular profiling of tumors had come, how the molecular profiling with technology changes and how the interpretation changes. And yes, having a prostate cancer getting divided like this, I had not thought. I thought it's adenocarcinoma. It's adenocarcinoma. It is not. You have not only that, you have a different types, and most important is this: looks like could be in near future, and that's what when I talk to people abroad, suggest that most of the trials in prostate cancer, they are coming now based on initial testing. And what Dr. Akhil told, that you're already doing molecular marker here. Good thing is Santosh is not there. I wanted to tease him. So when I said this center, many things what you do is not done in Tata Hospital. And many times me and Amit review it, that this is not right because of structure of the way organization develops. So again, this is for prostate cancer. So I don't know, Amit, so P10, RB1, P53, they all do it here. And it is not done in Tata Hospital. So I was very keen, if Santosh is there, I can tease him that it is being done at Varanasi Center, but it's not being done at TMH. So Patni Saab, thank you so much. You keep adding. Those are tests very important. And that's why you have subsequent treatment which will be coming based on these tests. And you are not going to have those trials, what I showed you earlier, that all comers and then we put a treatment. It will be different groups and then different treatment, either escalation or de-escalation. So patients who are not responding to docetaxel, why you want to give it? And how many times you find a biomarker? And here it looks like more than once when they have done these biomarkers are right, that they do decide which are going to benefit with hormone therapy, which are going to benefit with chemotherapy. So this will be hearing a lot. Maybe my post-retirement also. Thank you so much. Thank you so much.